All right. Good morning. I hope everyone can hear me. I'm Angie Selzer from the University of Colorado, and we have the smartest and most dedicated audience here with us today. It is 9:15 on the third floor. I don't know about you. It was not the easiest place to find, so I really appreciate everyone taking the time to be here on a Tuesday morning to come to this talk. This is a panel that I put together for a number of years now. Just because in my role as medical director of the pre-op clinic at the University of Colorado, we are constantly sort of bombarded with these oral board STEM type questions with patients who are presenting for a surgery who have this finding that nobody's addressed. And we, in our abundance of thoroughness, looking through the charts, bring up the fact that a patient has an aneurysm that nobody's told them about, and what do we do about that? And so looking through the evidence is not something we usually have time for on the morning of surgery, but something that we have more time for in the pre-op clinic. And it's something that I've always found very interesting. So this is our fourth year doing this. We have different topics every year. So hopefully we'll be doing it again next year with a slew of topics. If you have any ideas for incidental findings you think would be interesting, please let me know. I am very excited that this year the Center for Perioperative Medicine has chosen our talk to be one of their selected talks for this conference. And really very happy that the ASA has really shown the importance of the dedication of anesthesiologists and the unique perspective that we bring to perioperative medicine to create CP Med, or the Center for Perioperative Medicine. And it's really our honor to be a part of that education, and this talk is one of those. So I do not have any relevant financial disclosures. I do have a royalty from an up-to-date article, and I'm the vice president of SPACI. None of these things I don't think are going to be of issue here, and our other speakers also do not have any relevant financial disclosures. So the background for this talk, as I've said, we've given it for a number of years. Some prior topics that we've talked about are what to do about cerebral aneurysms, carotid stenosis, untreated rheumatoid arthritis, goiters, pulmonary emboli or nodules, aneurysms, prolonged QTC. And I have any of those slides if anyone's interested in seeing them. But some of the common themes of these situations are that most of these patients, at least in my experience, are asymptomatic. They probably don't know they have this condition. Oftentimes patients went to the emergency room for, say, shortness of breath and got a CT scan, and nobody told them, hey, you should get this, and you do have a thoracic aneurysm. You need to have that followed up. Or someone told them and they were so busy worrying about these other things they forgot about it. So they usually don't have any prior diagnosis or management. And when addressing any of these situations, the major points that you want to think about is how urgent is the surgery, number one. I mean, if it's an emergency, we're going to have to go ahead no matter what, and just taking into account the physiologic implications of those comorbidities is important. We want to think about what society guidelines exist for testing and medical management. A thing that comes up very commonly in our clinic is a patient who had mild valvular disease in an echocardiogram 7 years ago, while ACCHA guidelines do recommend repeat testing in 3 to 5 years, so which they haven't had, so we will send them for that. Thinking about how these conditions are going to impact our anesthetic management, and then also discussing, you know, if this is not a truly urgent surgery, do we want to sort of take a break, wait, reschedule surgery for a later date while we figure this out? So this is just a quick little algorithm that I put together to think about what to do with a patient with a finding. If you are like me, you know, maybe running 3 rooms and you have 18 cases that day, and now all of a sudden, you know, what do we do with this finding? You're going to try to figure that out. You're not going to be looking up society guidelines probably. So you're going to think about sort of the urgency of the surgery and proceed from there. So today's topics are really great. We have 3 really fantastic speakers. We're going to be talking about hyperthyroidism, aortic stenosis, and elevated liver-associated enzymes. Our three speakers today are Dr. Cummings from Cleveland Clinic, and Dr. Okocha from Northwestern, and Dr. Stewart from Stanford. And Dr. Cummings, we work together in SPACI. He is our illustrious treasurer. Yes, illustrious, Ken. All right, so please welcome our speakers. We're going to start with Dr. Cummings and hyperthyroidism. This is going to be a case-based presentation. My craniotomy patient has untreated hyperthyroidism. Now what?
Okay, well, that's the first time I've been called illustrious, so thank you, Angie. So, yes, I'm Ken Cummings. I'm from Cleveland Clinic. I'm the head of perioperative medicine there, and here to talk about a patient who shows up with untreated hyperthyroidism. Let's see if I can make this work. There we go. Okay, so here's a case. Most of the details are true. Some have been changed to protect the guilty. We've got a 55-year-old woman being seen in clinic a week before surgery. She's scheduled for a craniotomy because she has a meningioma. She's been followed over time. She had an asymptomatic meningioma, just followed with imaging, but now has started to develop some headaches, enlarging on the MRI, and some visual changes. So it's time to do something. Past history, she's on an ARB for hypertension. She's on the SSRI for anxiety. It says that she gets occasional palpitations and has actually had an unintentional weight loss over a few months. Still BMI is 30, heart rate was 130 and irregular, and she was hypertensive. So we got an EKG, and she was in AFib, 130s. Because of that, we just sort of reflexively checked a TSH, and it was very, very low. And her T4 and T3 were elevated, so indicating she's hyperthyroid. So now what? Do we say forget it? Do we go ahead? What's the next step? So just kind of keep calm, evaluate the patient, figure out what's going on. So vast majority of patients showing up with hyperthyroidism are going to have Graves' disease, about 85%. Much smaller number might have a toxic goiter or an adenoma, or the acute phase of Hashimoto's thyroiditis could present with hyperthyroidism. But, if I were a betting man, I'd say Graves' disease. And this has a lot of perioperative implications, particularly from a cardiovascular standpoint. Hyperdynamic circulation, cardiac output can be triple normal. And of particular relevance in this case is that cerebral blood flow is elevated by 10 to 20%, which would kind of complicate intracranial surgery. A lot of other things, the renin-angiotensin system, AFib, malabsorption, and hypermetabolism. So it's really, the question is, how does this modulate the perioperative risk, right? Is this significant? And it turns out the literature is not that great. So what you're seeing is the best I could find. So the first thing we note is that AFib is actually very prevalent among people with hyperthyroidism, and it's age dependent. So if you look at the graph there, its age kind of increases as you go to the right, and the prevalence of AFib is on the y-axis. And you can see if you have an octogenarian with hyperthyroidism, it could be 20-25% of people will have atrial fibrillation. So it's a fairly common problem. But what we're really concerned about, everybody thinks about hyperthyroidism, untreated, oh my gosh, it's going to be thyroid storm, right? Patient's going to show up and they're going to totally decompensate. It's like Monty Python. Nobody expects thyroid storm. It's actually everybody expects thyroid storm, but nobody knows when it's going to show up. And it's just decompensated hyperthyroidism. So tachycardia, fever, GI symptoms, delirium, and cardiovascular collapse. So it's a bad scene. The question is, what's the real risk of this? And it's hard to answer that. This is the best evidence I could find from BJA 4 or 5 years ago. And it was they gave it a fancy name of systematic review. It was basically a review of some case series of patients who were presenting for thyroidectomy. So they were known to be hyperthyroid. They were being treated, and they were coming in to have thyroid surgery. So this was not incidentally found hyperthyroidism. This was not all other surgeries. This was patients coming specifically for thyroidectomy. And the problem was that there was no pattern that they found, that even in patients who were treated, they had somewhere between 0 and 14% chance of having thyroid storm. So evidence out there on thyroid storm is poor. Certainly with medical management, it seems to be very, very rare. And so I think it's one of those things that we all worry about, but may not be as prevalent as we think it may be. So if we talk about treatment, how do people get medically treated for hyperthyroidism? And mainstay is thionamides. So these inhibit thyroid peroxidase, inhibit the organification of iodine into the colloid proteins and the formation of thyroid hormones. So methimazole is the most common in the US. There's propylthiouracil, which some people say theoretically has a benefit because it also blocks peripheral conversion of T4 to T3, but it's dosed inconveniently, has a very short half-life, and most people will go with methimazole. Then beta blockers treat the adrenergic symptoms. And again, traditionally people say, well, propranolol is great, nonspecific beta blocker, but it also blocks peripheral conversion of T4 to T3. Challenge there is that it takes a long time for that to work, and you have to use really high doses of it. So the thinking, at least in the endocrine literature, has swung back to just using selective beta blockers like metoprolol or atenolol. Dexamethasone is good for temporizing, also blocks peripheral conversion, or if somebody's hypermetabolic. And then in extremis, you can give iodine. Through the Wolff-Chaikoff effect, inhibits the uptake of iodine by the thyroid. But again, it's transient. So in the pre-op clinic setting, we're going to be giving a thionamide and a beta blocker usually. But that raises the question, if we're going to postpone surgery for treatment, how long are we going to wait? And here's another thing where the data are not very good. Everybody's got a recommendation. A lot of people quote the AAFP, which says, wait 4 to 6 weeks. And their evidence is expert opinion. So the best I could find was about 30-year-old study from Germany, where they took patients who were clinically hyperthyroid, and they started them on methimazole on one of 2 doses, and they followed their thyroid hormone levels and TSH levels over time to see, okay, at what point does somebody become biochemically euthyroid? And it's a little tricky because it depends on what you look at. They're looking at actual thyroid hormone levels like T4, T3 because they have much shorter half-lives. If you're following TSH, you're going to wait a long time because it's a lagging indicator. So what they found is after 3 weeks, somewhere around half of patients were euthyroid, depending on the dose. At 6 weeks, the majority, and at 12 weeks, just about everybody. So, the 4 to 6 weeks seems to be kind of reasonable based on this. So if we come back to the case, because it wasn't critical that she proceed in 1 week, we postponed the surgery, had her see an endocrinologist, and they agreed that they thought it was Graves' disease, started her on methimazole and atenolol, started a rate control strategy for the AFib, and came back 4 weeks later for labs. TSH was still suppressed, but not surprising. But her other studies were much better, and she felt much better. So 6 weeks later, came back for craniotomy, did well, followed up with cardiology, ultimately converted out of AFib. So that's all well and good, but what if this is something that can't wait, right? And so I'm kind of dating myself here in the 1970s emergency. It's a great show. Anyway, so look it up, YouTube. So there are many ways people have described how to do this, and it's kind of like, here's our protocol, here's our protocol. But the basic premise is you give some source of iodine to suppress uptake, you give steroids, you give an antithyroid drug like methimazole, and you treat the adrenergic symptoms with beta blockade. So in this case, I thought it was interesting, they were using a radio contrast medium as an iodine source. Not recommended anymore. People generally use potassium iodide. But this was interesting, and they showed that at 4 days, they had the majority of patients biochemically euthyroid. So you can treat it acutely and rapidly if you have to. Certainly requires inpatient treatment and close monitoring. So that's not something we'd be managing directly in the preoperative clinic, but it's something where you need to get the ball rolling. So if I were to sum this up, should I stay or should I go? I think that if you're going to go, patients having elective surgery who are subclinical, they're not symptomatic, and it's biochemical hyperthyroidism. It's not significantly elevated T4, TSH. Probably reasonable to go just because of a lack of evidence and the fact that we do it a lot. But if patients are symptomatic and it's urgent, acute treatment is necessary to ideally wait a few days to try to get things stabilized. But certainly if it's elective or even time sensitive, you can wait a couple weeks, you can get things under better control if they're clinically hyperthyroid like this patient was. I thank you for your attention, and I will hand it over. Is it Dr. Stewart now, or Dr. Okocha? Okay.
I know, right? Good morning. I know. Okay. So I'm going to be talking about aortic stenosis. So my topic is my patient has knee arthroplasty plan, but also has aortic stenosis. Now what? Is this working? No, hold on. This and this are different.
Yeah, it's showing up as the other one, so let's just go back.
Escape.
Yeah, escape.
There we go.
Okay,
That's fine.
now we're good.
Yep.
Okay.
Okay. So objectives, just to understand the pathophysiology of aortic stenosis, review the current ACCHA guidelines on this topic, and identify indications for when surgery should be postponed for further optimization. So here's our case. 73-year-old lady going for a knee replacement, BMI of 34, severe aortic stenosis, and is really eager to get this done because she has knee pain. So it's really rare to have somebody this age who just has severe aortic stenosis or just a significant medical problem, but this was our patient. And this was her echo finding. Normal EF, normal RV function, but the valve area was next to nothing. Peak gradient was significantly elevated, and the mean gradient was 60. So all of us would be so excited to do this case. Can't wait. I mean, immediately, as a matter of fact. So we saw her in our clinic, and our exam validated these findings. Not that we needed the exam to do that, but the diagnosis of AS includes physical exam, of course. And in her case, she had a cardiologist that had been following her, and this was not an incidental finding. But she denied any symptoms. So typical symptoms can be present, but in her case, they were absent. So no dyspnea, no angina, no presyncopal episodes at all. So when we saw her, we were like, great, you have a cardiologist. So we sent her back. And this was the response. Basically, she's asymptomatic. I saw her a couple of months ago. She can proceed with surgery at intermediate risk for adverse cardiac events. We're all so excited. Can't wait. So what do we do now? What are our next steps? We've done our due diligence to refer her to the cardiologist. And, like I said, patients eager to proceed. So I'm just going to touch on a few things on diagnosis of aortic stenosis. So as we know, echocardiography is the primary test for diagnosis and evaluation. It allows us validate the presence of stenosis, the severity based on valve area, valve velocity, transvalvular velocity, and mean gradient. It also assesses the left and right ventricular function and size. All of these are important in correctly defining the severity of aortic stenosis. And so just bringing us back to our case, this is her echo finding. And the ACCHA guidelines from 2020 actually describe various progressions of aortic stenosis. So stage A is at risk, so you're a patient with congenital valve disease, like bicuspid aortic valve, or patients with valve sclerosis. Those are at-risk patients. Progressive are those that have mild to moderate stenosis. Stage C would be patients that are asymptomatic severe AS, and then stage D are patients with symptomatic severe AS. So our patient falls in this group by definition. And in her case, it's actually very severe based on the mean gradient of 60 or above. In her case, she also has normal EF. And so now what? The cardiologist is giving their input. They recognize the valve area. They recognize her normal EF. They recognize her significantly elevated mean gradient. What do we do? So we call the patient and she says, I'm telling you, I have no symptoms. I'm doing great. But I know I haven't really been able to do much over time because, my knee hurts. I've been dealing with this knee for a long time. I just need to get the surgery done to get back with my life. So now what? You've done your due diligence. You've sent her back to the cardiologist. You've reassessed the patient, and you're stuck. So what did we do? My first thought was, well, I need to get a second opinion. And my second thought was, well, if they say the same thing, I'm going to have to pick this anesthesiologist really well. And so I looked up the literature, and thankfully, at the time, the 2024 guidelines weren't available. This was last year when we were picking this topic. It wasn't available, but it builds on the 2020 valve guidelines. And essentially, it says patients with severe valve disease should be evaluated. And a cardiologist's statement is not an evaluation. There is a process to the evaluation. This is a class 1 recommendation. And so, thankfully, since the time I saw this patient, they have come out with really explicit guidelines and algorithm that is practical and easy to follow. And we'll look at it in context of our patients in the next slide. So in her case, she has severe aortic stenosis requiring elective non-cardiac surgery. We had sent her to the cardiologist. We're kind of in a bind. The surgeon was well aware, and he's like, do whatever you can to make sure she gets her surgery safely. And so we went down the algorithm. She insists she's asymptomatic. And in her case, she has normal EF. But what would the surgery risk be? So one thing to note is that the new guidelines no longer differentiate between low, intermediate, and high risk. It's either low or elevated risk. And these risks are defined by, your, risk calculators that you have out there. RCRI is one of the ones that are out there that people are usually aware of, but it doesn't capture the breadth of surgeries we do today, right? It typically focuses on intra-thoracic or intra-abdominal surgery, and so orthopedic wouldn't be covered in this. But there are other risk calculators that can capture, the risk of major adverse cardiac events. So either MICA or the NESQIP risk calculator can be used. And in her case, she was greater than 1% risk for adverse cardiac events. Other things to consider where the surgery in of itself may not be calculating as elevated risk, as your surgeon, right? Are these cases tending to be more of a major blood loss case, large volume shifts, significant hemodynamic instability? Those cases will also qualify as elevated risk surgery. And so in our case, I would say knowing that her MICA was greater than 1, this is, the role that we play as anesthesiologists to feed into this algorithm. It was not reasonable for her to proceed. So we elected to delay because we can, in fact, delay. And we now have to decide, is she a candidate for valve replacement? So there are many factors that go into this decision. We're not all privy to it. One of the main ones are comorbidities. As I mentioned earlier, she doesn't have any significant comorbidities, so that was one thing going for her. Other things are anatomy related in terms of can the valve be properly placed? That's up to the cardiologist. But in our perspective, everybody agreed that she would be a candidate for valve replacement. And so now we have to evaluate this patient. What does that mean, evaluating for elevated risk surgery? So this goes back to the 2020 guidelines. And essentially, it recommends diagnostic testing with exercise stress test. And in her case, she's asymptomatic stage 1C, like I alluded to initially. And so it's reasonable to assess any physiologic changes to the valve with exercise to confirm, in fact, that she has no symptoms. And that's what we did. So now what? We've all agreed, the cardiologist's second opinion, not the initial one. The surgeon, we're all on the same page. We're going to defer. What are we going to do for her now? So we elected for low-dose dobutamine stress echo was considered, knowing that she couldn't exercise because her knee hurt so much. But however, after further consideration, just based on the valve area alone and knowing that the surgery was elevated risk, we proceeded to get TAVR for her, but after a cardiac cath just to rule out significant CAD. So additional considerations for patients with severe AS. Any patient that has severe AS should have an echo within a year of their surgery. If they have new symptoms or worsening symptoms, they need to have another one, even if it was just, a couple of months ago. Valve replacement, TAVR or surgically, actually reduces risk perioperatively. Patients with asymptomatic severe AS and normal LV function can safely undergo low-risk non-cardiac surgery, especially in the absence of severe CAD. And so again, our expertise is determining the risk of the surgery. So low risk, I think many of us will agree, things like cataract, really peripheral things like, hand surgery, those kinds of things would be more along the lines of low risk, but that's where our expertise as anesthesiologists come into play. And then for urgent procedures, cases that you cannot defer for any extended period of time for valve replacement may benefit from balloon valvuloplasty as a bridging therapy. So in summary, all patients with severe AS must be evaluated by the cardiologist, preferably a valve specialist. Defining surgical risk is critical. This is where our role as anesthesiologists, we're best equipped to answer. Valve lesions have a slow, insidious rate, so patients don't really appreciate the effect of the valve lesion on their activity level. We all know this, the exercise tolerance per patient report is typically unreliable, and cleared for surgery is not necessarily acceptable. That's all I have. Thank you so much. And Dr. Stewart will be coming up. I don't know how to do this. Okay. Yeah, that trap.
Yeah, there is.
Thank you.
Your orthopedic surgeon's going.
Thanks for looking out for us.
Appreciate that.
I'm an anesthesiologist.
Yeah. Okay. So you can also use this. There's a laser pointer if you want.
It's
Okay.
better to use that.
No, it doesn't matter. Or you click here.
Oh, okay. That's fine. All right, great. Thanks for having me. I'm going to be speaking about a lumbar fusion patient with elevated liver enzymes. I have nothing to disclose. Oh, thank you. So when Dr. Selzer gave me this topic, the first thing I thought of was, oh my gosh, this is so broad. We could do, hours of lecture on this. I will try and keep it to the high yield points. But I do feel like this is a topic that comes up a lot in our evaluations because liver enzyme elevations can be, somewhat subtle. And a lot of times people have no idea what to do with them. So in this case, this was a 62-year-old male who presented for a pre-op evaluation prior to a multi-level lumbar fusion. You notice that a comprehensive metabolic panel from the year before reveals an AST elevation, ALT elevation of 84/97. As you're reviewing his history, you note that he has no allergies, he has type 2 diabetes, hypertension, he has a BMI of 46, hyperlipidemia, and chronic low back pain. He had an uncomplicated hernia repair many years prior. He drinks about 2 or so drinks per week or per day, most days of the week. No tobacco, recreational drug use. He is able to achieve more than 4 METs. He's on ibuprofen and Tylenol for his back, gabapentin, glipizide, losartan, HCTZ, and atorvastatin. So probably a patient that all of us see pretty frequently on a day-to-day basis. So being very astute and paying attention to those abnormal liver enzymes, you decide to take a more targeted history. You screen him for risk factors for exposure to viral hepatitis. You inquire about his vaccination status, his prior screening. You ask him a little bit more about his alcohol use, confirm his medications and supplements, whether or not he has a family history of inherited disorders or people in his family with liver disease, and think about whether or not he could have metabolic syndrome. On physical exam, you target your exam to findings of chronic liver disease like jaundice, ascites, splenomegaly, etc. When you send repeat labs, you find that he has mild thrombocytopenia to 112. His creatinine's a little elevated. His AST, ALT are once again somewhat mildly elevated. His albumin is 3.3. His ALP is 150. His T-bill is 1.3, and his INR is also 1.3. So we're going to take a little bit of a time travel back to medical school and intern year and do a brief review. I will try to keep everybody awake on Tuesday of ASA about liver enzymes. Thank you for this gift. But it really, ultimately, your next steps in your preoperative evaluation depend on making the correct identification of what are the processes involved, because there are so many things that can cause these abnormalities. So ALT is elevated in hepatocellular injury. It's more specific for liver damage. AST increases as well with hepatocellular injury, but it's less specific and found in other tissues. ALP is found in the liver, but also bone, kidney, and intestine and placenta, which is why pregnant women tend to have a little bit higher ALPs during pregnancy. GGT is found predominantly in the hepatobiliary system, but also other tissues as well. Bilirubin is usually reported as a sum of total, or reported as total or sum of direct and indirect. I think of direct as being somewhat like pre-liver bilirubin. It's formed from red blood cell breakdown. It's transported to the liver bound to albumin. Indirect or conjugated is made in water-soluble form initially in the liver. Then the liver adds a sugar molecule, and then that water-soluble form is excreted in the bile. So INR is a measurement of synthetic function and how the liver produces these clotting factors. These clotting factors have very short half-lives. So this makes this a very exquisite measure of hepatic synthetic function, but not a great measure of bleeding risk for people that have cirrhosis or impaired liver function. So when I'm thinking about transaminitis and interpretation of my LAEs, I think about magnitude and pattern. So how high are they, and also what is sort of the ratio between the two? So when AST/ALT are less than 300, it can be pretty nonspecific. There's a lot of things that fall in this category. But if you break it down by pattern, it can help you differentiate out what you're thinking about. So in ALT predominance, think about things that really intrinsically affect the liver. So chronic viral hepatitis, drugs, toxins, Wilson's, hemochromatosis, alpha-1 trypsin deficiency, and then MASLD, which, if people aren't familiar with that acronym, that's the new acronym for things like NASH or NAFLD or what have you. It's metabolic-associated liver disease. So we rename it every so often just to keep everybody on their toes. If the AST/ALT ratio is less than 1, it's more suggestive of hepatic steatosis, and ALT linearly increases with BMI. AST predominant patterns include things like alcoholic hepatitis, cirrhosis, sometimes also MASLD. Early processes, this is like the one thing everyone learned in medical school, that the 2-to-1 ratio of AST and ALT is suggestive of alcohol use. And then if AST is much, much greater than ALT, maybe think about an extrahepatic source like rhabdomyolysis. And then once we have AST/ALT in the thousands, hopefully we're not seeing patients like this in clinic, but I did have one. It was actually when I was working with you. That came in. She had not really had a lot of access to medical care and was presenting with autoimmune hepatitis and bought herself a very swift admission. But these are things like ischemia, vascular obstruction, shock liver, drug toxicity, autoimmune hepatitis, severe viral hepatitis, severe biliary obstruction, and anything in between the hundreds to the thousands is really like progressive and overlapping processes. So bilirubin, so isolated or predominantly indirect elevated bilirubin. We think about hemolysis, some inherited disorders, hematoma reabsorption, some drugs. Predominantly direct elevated bilirubin. So we think about more obstructive processes, sometimes hepatocellular disease as well, Dubin-Johnson syndrome, cholestasis of pregnancy, infiltrative diseases, et cetera. And one way to kind of differentiate between this sort of biliary obstruction versus hepatocellular injury is something called an R value. Can help you parse out the difference between the two. And don't worry, guys, we're almost done with the review, I promise. And then I get asked about this all the time in clinic, these isolated ALP elevations, what do we do with them? And so in adults, a lot of times this is due to bone turnover. So the not to miss diagnosis is, does this person have metastatic cancer to bone? Sometimes drugs can induce this. Early malignant biliary obstruction will also present sometimes with an elevated ALP. And interestingly enough, there's physiologic elevations like pregnancy, or if any of you guys are blood type O and A and you have a Big Mac, that'll do it too. And if you are trying to parse out where that ALP elevation is coming from, it's always helpful to send a GGT, and that will tell you whether or not that's hepatobiliary origin or extrahepatic. So getting back to our patient, when you question him further, he does admit to drinking maybe a little bit more, to 2 glasses of wine a week. You can thank our ever-enlarging wine glasses for this. You order a right upper quadrant ultrasound that's suggestive of cirrhosis. So now what do you do? So first steps would be thinking about risk stratification for elective surgery. So classically, we use the Child-Pugh classification system, which relied on patient-specific factors. And patients that were Class C were sort of prohibitive for elective surgery. It was really maybe consider transplant first or non-medical or non-surgical interventions, whereas A could proceed with no issues and B was sort of a judgment call. There are some flaws with this scoring. It doesn't really take into account the subjective nature of trying to decide about ascites and encephalopathy. It doesn't take into account renal function, which we know is a huge predictor of peri-op mortality in these patients. And then it didn't take into account the type of surgical procedure, urgency, and patients were not really adequately differentiated in terms of their severity. So then along came this. This is the Vocal Pen score. This is actually the preferred tool by the American College of Gastroenterology for perioperative risk stratification. It's very easy to use. It's superior to MELD and CPC, both in discrimination and accuracy. Discrimination and calibration across multiple studies and diverse patient cohorts. It looks at both liver-specific variables as well as surgery-specific variables and whether or not that's the urgency of the procedure. It's very well validated externally, and there's been one study that did suggest that maybe it performed a little bit less well in urgent surgeries and patients with diabetes or abdominal wall procedures, but overall this is a pretty reliable tool. So the other question that comes up frequently is, with patients, when do you send them for a transplant eval? So I'm on the liver transplant team at my university. We come across this not infrequently. We get asked about this. And the last thing any of us that are a part of a liver transplant center want to be doing is scrambling for a last-minute emergent evaluation for someone that had an elective surgery that then decompensated. They'd much rather see those patients beforehand and determine their candidacy in a situation that's not time and stress sensitive. So patients that are at the highest risk for postoperative hepatic decompensation should be considered for transplant candidacy prior to elective surgery. Those patients are generally people with MELDs equal to or greater than to 15 or CPC Class C or other signs of decompensated chronic failure, so ascites, hepatic encephalopathy, variceal bleeding, et cetera. With MELDs less than or equal to 12 or CPC-A, they really don't require referral for evaluation, but they probably should undergo multidisciplinary optimization. And in between, it's a little bit of clinical judgment, taking into effect the urgency or severity of the surgery, the patient, and it's never a bad thing to get a referral to hepatology early on if we're able to do so. Last, I want to put a quick plug in for alcohol cessation in the perioperative period. I think this is an area where we can be really impactful both on postoperative outcomes and also just the long-term wellness of our patients. We all learn that when patients are admitted or having surgery, this is really a unique time in their lives where they tend to be more open to behavioral interventions and lifestyle changes. With screening tools, one thing that's really important to remember is that none of these are diagnostic for alcohol use disorder. These are all just help guide you as to whether or not that patient needs further evaluation. CAGE is a very commonly used questionnaire. It's easy to remember. It's got a nice little catchy acronym. It's probably a little less sensitive than other tools. It doesn't catch mild alcohol use. quite as well, but it's very easy to administer it, and it's usually done with the clinician asking. Audit and Audit C are self-administered, meaning that usually that's sent out to the patient and they answer that in the privacy of their own time. Audit C is really just sort of an adapted 3-question version of Audit, so it's a little bit easier for screening purposes. These are a little bit more sensitive than CAGE. Any self-administered test tends to be, because I think people probably feel a lot more comfortable reporting their bad habits in their own privacy than they do with someone face-to-face asking them. And then last, interventions in the perioperative period. This is really an area that has gotten a lot of attention in the last few years. This Cochrane review was a little old. It was in 2018, and there's certainly been some great RCTs since then, but I think this really highlighted well a lot of the interventions that are out there. This was done by Engelholm. It included 3 RCTs, 140 participants, and preoperative programs were usually about a month to 8 weeks, a month to 2 months in advance. They included interventions such as outpatient pharmacological withdrawal, which I think is fascinating and a really interesting arm in some of these studies. Structured patient education, intensive counseling, relapse prevention, and this all reduced post-op complications by 40%, which is pretty remarkable. The participants had high rates of complete alcohol cessation after control, so this really shows that we can have an impact on patients' health and well-being well after surgery and well after they leave our preoperative clinics. The effect on in-hospital and 30-day mortality were inconclusive, but these were really small studies that were done, fairly small studies done with mostly male participants in Denmark, so definitely highlights the need for more research in that area, and that certainly is ongoing since this study was published. And this all really shows the need for intensive clinic-based alcohol cessation prior to elective surgery. I think it's an area where we could do so much better as a specialty. And in this case, this patient very much would benefit from this. All right, and then that's all for me.
Awesome, thank you so much. So we actually have time for questions, and if anyone has any questions, you can come on up to the microphone. In the meantime, while folks are thinking about what questions they want to ask, I have a question for Dr. Cummings about hyperthyroidism. So I think all of us would agree a patient with non-rate controlled newly diagnosed AFib is not a candidate for surgery. But if that patient came in with the same TSH, not an AFib, mildly tachycardic, well, or let's say a heart rate in the 90s, what would you do with that patient? I'm asking because I've seen that patient in my clinic.
in this very same circumstance, like
Yeah.
kind of subacute need. Well, certainly AFib would tip me over the edge to not do it, but in the setting of mild tachycardia, is it from hyperthyroidism? We don't know. But if there are adrenergic symptoms, I would want to get those under control first. So, do we need to wait 4 weeks to get euthyroid? Maybe not, but starting a beta blocker and starting the process of getting her treated would be helpful.
And if I'm seeing that patient for that surgery in the pre-op clinic, not in the pre-op clinic, in the pre-op area, everybody's ready to go. The surgical, tools and equipment are all out in the room, and she's got this symptomatic meningioma, and I see this lab that's abnormal with no diagnosis of hyperthyroidism. You think it's safe to proceed in that patient?
With just a lab?
Just the lab.
I would probably proceed. I mean, if she were totally asymptomatic, not tachycardic, et cetera.
Okay. I am going to ask a question then for Dr. Stewart. So then I don't know that we got the conclusion with that patient. So what ended up happening? Did we do alcohol use cessation? What did he end up doing?
This was a fictional patient, although I've seen this patient many times in different forms. I would say that I would venture to guess that if you did actually, just because I'm so used to looking at these scoring systems,
Yeah.
my daily job, I venture to guess if you actually put his data in, he probably would fall into a low risk category. He probably would be like CPC A or B. Probably vocal pen score would be acceptable. And so in that case, it would never hurts to get a hepatology referral and get those patients set up before surgery, because that, of course, like surgery throws a loop, wrench into everybody's lives, and then his follow-up is in a year, he doesn't do it or have you. So I think that's a unique time where you can really get someone in expeditiously for evaluation, and then he can begin to be tracked. So I don't think he would be someone that we would really be serious about evaluating for candidacy.
Okay.
I think someone like that, though, would be an excellent candidate for any of these interventions to help reduce his alcohol intake and maybe help him on a path to sobriety if that's appropriate. But I don't think in this case, I don't think this case would have been canceled or delayed significantly. But if we had these programs available to us and we wanted to push it back a little bit so that he had time to participate in that evaluation and in a cessation program, I think that would be a great thing for him.
We've just started doing alcohol use disorder referral to CEDAR, our substance use disorder clinic, and they do virtual meetings with patients and then start them on medications to try to get them through. Oh, okay. Okay, I'm just going to repeat the question because this is being recorded, and so you probably aren't, people listening to this on the recorded line don't necessarily hear what you just said. So you just asked, how do you refer for alcohol use disorder? Is it psych, is it PCP, or substance use?
I think it really depends on the capability of the system you're practicing in. And I have the good fortune of being at a large transplant center with with addiction medicine and a lot of resources. And University of Colorado is also like that too. They have an excellent outpatient and patient program. I think in lower resource settings, starting with the PCP is not a bad idea. I think considering what is safe withdrawal, and this is why I said this topic could be like a whole nother lecture in terms of how to approach these patients, but considering safe withdrawal, there's a lot of nuances to that and what patients are appropriate for inpatient withdrawal or outpatient withdrawal and which really do need to be inpatient withdrawal. So that's a larger conversation that if we don't have expertise in, we probably should defer to the PCP or just straight to addiction medicine if that is available to them. Now, if they're showing symptoms of withdrawal, I think that's a different story, and maybe that would be someone I would consider going to the ER so that they can either temporize them with long-acting benzos, or if the patient's interested and engaged, then doing an inpatient withdrawal protocol.
And patients with alcohol withdrawal in the hospital have a very high rate of delirium, prolonged ICU stays, so that there's a lot of interest in helping prevent that. I do have one more question about the cirrhosis patient. Do we need to screen them for varices? Like, what are the recommendations for someone with a new diagnosis of cirrhosis? Did that come up in your research?
It does. Sorry, then had my 10 minutes and trying to do the broad topic. But yeah, that is part of the initial evaluation. I don't think, though, I think it probably depends a little bit on the patient's bleeding history, the severity of their portal hypertension, whether they would need to be screened and banded ahead of time of elective surgery, or whether or not they could proceed, and then, of course, in the context of the urgency of that surgery. So I think that's really where your hepatology colleagues come in handy, and they can give you a little more nuances to the risk involved in something like that. But certainly if someone's had a bleeding risk history and they haven't been evaluated, they haven't had their varices evaluated in the past, or they are a higher MELD, those are people that I would push harder for that screening to happen before elective surgery.
Awesome. Yes.
Thank you, Chris from University of Florida. I think when I'm going through the mental gymnastics of do I want to do this case or not do this case based on the findings you get often pretty immediately before, I kind of lean a little bit on the post-operative phenomenon, because I think most of us can get them through the case quite well. And then it's okay, so now they're in the PACU, now they're on the floor, now they're at home. Can you weigh in a little bit on when you consider the post-operative course and how it could be deranged and how that weighs into your calculus in the pre-op clinic?
Yeah, definitely. I think that's where vocal pen comes in really handy, and other risk stratification systems like MELD, for example. Because when we identify a patient that's at risk for compensation, then there's not there's not a ton we can do intraoperatively to avoid that other than good care, right? Like avoiding hypotension, like the cardiology recommendations,
Yeah.
avoiding hypotension, fluid overload and all these
Hyperkaria.
things. And are there less, invasive interventions and that sort of thing? But having that patient evaluated for transplant candidacy ahead of time is just so important for these high-risk patients, because I've been a part of evaluation processes where patients have decompensated afterwards and had not had an eval prior to that. And we make bad decisions, because at that point we're making a decision of, if we don't give this patient a liver, this person's not leaving the hospital. And that's a very difficult ethical position to be in when you're on a transplant committee, as opposed to preoperatively, you're making that decision without that pressure. And then if they aren't a transplant candidate, then that might guide the surgeon and the patient into, maybe we consider non-invasive intervention. Are there other things we can do for palliation, that kind of thing? I think you're absolutely right. We can get most cirrhotics through, I get cirrhotics through liver transplants all the time. It's pretty rare that the intraoperative course is the big issue. But making sure that there's good communication with your hospitalist service or the surgical services, whoever's managing these patients, that they understand the risk, they know what to look for, and that these patients, for example, may not be eligible for same-day surgery. Maybe they are someone that needs to be admitted overnight or plan for a longer stay. Maybe we do need to plan, talk to the surgeon about surgical planning and whether or not less invasive methods are available to us, and that kind of thing. So it really is having a multidisciplinary approach and thinking about very holistically about these patients are important.
Do either of you have anything to say towards that question with your case, your patients or at your institutions?
Sure. I mean, similarly, I think, like we've all know, taking care of, look at my case, a patient with critical ES is possible. But at the end of the day, we have to remember that our role in caring for these patients is that we want to get them better than how they were when they came in. So sure, we can get them through the case, but afterwards, what's the outcome going to look like? Are they going to, go to the floor, go to the unit? I mean, if those were the expectations, maybe, but I doubt that any patient coming in for a knee replacement is expecting to go to the ICU with potentially extended stay.
And that patient who, I've seen that patient in clinic too, and, their report of asymptomatic, because they've been, as you said, it's an insidious track, and so they've been slowly reducing their activity. So not having symptoms is not really a great sign. And that patient, had her valve not been corrected, may not have been able to participate in physical therapy. She may not have had a good outcome with the placement. Yeah.
And I agree. A lot of, it's a balance. Making sure things are appropriately managed preoperatively is important, but also, as perioperative physicians, it's critical that we're arranging things for postoperative care, flagging high risk, involving the right people, making sure that any postoperative issues are mitigated as well. And I think that's an equally important part of what we do in the preoperative phase.
Absolutely.
Hi. Yeah, there we go. Okay. So I don't really want to pick on the eminent Dr. Cummings, but
Illustrious, I think.
hypo rather than hyperthyroidism. And when does it start being a problem? Two cases. Neither one was mine, but one, the TSH was like almost 60, and the heart rate was 40. I suggested they not go ahead. My colleague went ahead, and I got to run in and stick in the pacer in the middle of the case. The other end of the spectrum, somebody, the TSH 8.5, probably asymptomatic, heart rate of 70. I mean, when does hypothyroidism become a risk factor?
Well, that's, yeah.
I mean, it's a black and white question,
Was that last year?
Yeah.
Yeah. But, well, you have objective evidence of hypothyroidism, right? So bradycardia and, a sky-high TSH. Again, the recommendations from people who claim to know such things are that if it's subclinical hypothyroidism, meaning if you can honestly look in a mirror and say that, yeah, I think this patient doesn't have symptoms, then people who claim to know such things would say to proceed. Whether or not they're right, again, a lot of this is expert opinion. The data are not good. But certainly if somebody's bradycardic, I wouldn't proceed.
I would add, I mean, we covered this a little bit last year, or a lot last year. So I think the perspective should be, if you think about it, a patient, say, who has diabetes and their A1C is 14, right? Of course we can provide the anesthetic. Of course we can take care of them. But is that the right thing to do? And so the thought process is, where we can optimize the patient, we should optimize the patient. And if we have the luxury of time, that should be the case. I think oftentimes our surgical colleagues may not necessarily appreciate all of that. You know, they're thinking your hat is the anesthesiologist hat. Oh, you're thinking this is an anesthetic problem, but not necessarily so. This is more of a perioperative concern. And so, you know, I would argue we should be not educating per se, but advocating for our patients to get, you know, as optimized as possible whenever possible. So yes, there's production pressure. Day of surgery, you're looking at the patient, the surgeon is standing there and they're like, excuse me, why aren't we going? But we have to still think of the patient holistically.
Yeah, I completely agree with that. I think that the question is never really, can we get the patient through surgery? Because we can always get the patient through surgery. We can put in a transvenous pacer. We can do whatever we need to get the surgery through. It's really more about, should we get this patient through surgery? And that's where we have the luxury in the pre-op clinics when we have anesthesiologists involved to help sort of head these problems off well in advance so they don't become our colleagues' problems in the pre-op area when we really don't want to cancel a case. Everybody's there. They may have traveled from far away. The OR is ready. Everybody's ready to go. Usually the way I phrase it with a surgeon is, and this has been very successful for me, I've only had to cancel one case, is I will say, I can get this patient through with a heart rate of 40, sure. But how are you going to manage the bradycardia afterwards? I think that's going to be a problem for the patient. Do you have a plan for managing it? And the surgeons do typically have to manage whatever the comorbidity that we're dealing with in the operating room. Someone's going to have a plan for managing it to get the patient out of the operating room, out of the hospital, sorry. And surgeons, they don't want to be doing that usually. So that's typically the approach that I take. Because and that's what I really try to teach our trainees as well is, you know, we have patients who are shot in the chest or hit by a car, and we get them through, surgery. Are those patients optimized? No. So it's never really a question of whether or not we can get them through, because we can almost always get them through. All right. Well, thank you so much to our speakers. Thanks again for everybody who showed up on a Tuesday at 9:15. Have a great rest of your conference.